Okay, so Clay here again, today with a 59-year-old male with chest pain of several days duration and a cough. So going over our steps of reading an EKG, first starting with the rate. So using the big box method, so 300, 150, 100, so a little bit less than 100, so roughly around 85 beats per minute. Then looking at your rhythm, looking at P waves. So we have a P wave, we have a narrow complex QRS, we have a P wave, we have a narrow complex, we have a P wave. So we seem to have a P wave before every QRS. We seem to have a QRS with every P wave. So overall sinus rhythm. Then looking at the axis, looking at 1, we have a positive deflection in 1. And in AVF, we also have a positive deflection, so a left axis. Then looking at all the other stuff. So a patient that comes in with chest pain of several days duration and cough, you're probably thinking pericarditis. So the number one thing you may see in pericarditis is ST elevations. But unlike the myocardial infarction, in which you have a pattern of ST elevations such as 2, 3 AVF for an inferior wall infarct, 3, 4 for an anterior wall infarct. This one you have ST elevations diffusely. As you can see them in 1, you see them in 2, you see them in 3, you see them in AVF, you see them in 4, 5, and 6. So you have ST elevations everywhere. And then throw in the clinical picture of also a cough and several days of duration for the chest pain, you're leaning more towards the pericarditis. Another difference between the pericarditis as well as the myocardial infarction, remember in the acute myocardial infarction, the ST elevations have the tombstone shape. They're convex, as opposed to in pericarditis, it's kind of like a happy face. You can see it's curving, it's upwardly concave. So if you saw two little eyes here, it could be a little happy face, which is pericarditis. Other abnormalities you can see, the red arrows are pointing to the hyperkalemia. So peak T's, think hyperkalemia. And a peak T is usually considered a T wave that is greater than 6 millimeters in the limb leads and 10 millimeters in the precordial leads. So you can safely say that all the red arrows are pointing to peak T waves, and in this case would be because of hyperkalemia. Another thing you can see is a little bit of, especially in V4, is the electrical alternans once again. And if you have a patient with pericarditis as well as electrical alternans, as you see here, you see QRS shorter than this one and then shorter as again, and there's just a variety of heights within the QRX complexes. In a setting of electrical alternans with pericarditis, you're thinking a precardial infusion, which could be a medical emergency. So we'll go over pericardial infusions in another video again, but just over here in V4 is significant for the possible pericardial infusion. And then pericarditis often takes a stage approach to the changes that you'll see in an EKG. There's generally 4 stages. The first stage, you can see ST elevation in almost all the leads, as you see in this pattern. And then stage 2, the J point, the ST junction, begins to decrease and return a little bit closer to baseline. The T waves will invert in stage 3, which you can't appreciate in this EKG. And then finally, stage 4, the EKG returns to completely normal as the pericarditis resolves. And then there's other clues that can point you to pericarditis. You can have sinus tachycardia, which this patient doesn't have because we said they're roughly around 85 beats per minute. You can have PR depression, especially early, and you can see PR depression in 2, 3, and AVF as well. You see the PR depression here here, and here. Another clue, you can have the low voltage QRS, which you can appreciate in 1. And then, like I mentioned before, electrical alternans in the setting of pericarditis can clue you into a pericardial infusion. So as far as this pericarditis EKG goes, that's it for today, and thank you.